Hello, everyone. Welcome to the Got Injured NJ podcast. Today, we're going to have, I don't even want to call him a guest because he's a part of this podcast and will be a regular here because he has just such a wealth of knowledge when it comes to the medical aspect of personal injury. We have Dr. Dorri. He is the founder and the physician at NASPI, which is North American Spine and Pain Institute. Dr. Dorri.
Thank you, Nima, for invite, and it's a pleasure to be in AmeriLaw Firm, one of the best law firms I know and worked with for a long time. Very professional and really top of the line. I give it to you.
I appreciate you, brother.
I'm Daniel Muhammad Dorri. I'm doing pain management for last 14 years in New Jersey, Northern New Jersey, in Bergen County, Essex County, Passaic, and Hudson County. I'm a pioneer in minimal invasive procedures in the spine and also treat patients who are victims of motor vehicle accidents or personal injury issues, as well as work compensation for over 14 years.
So Doug, a lot of the people listening to this podcast are not just people who've gotten into accidents, but they're also attorneys and otherwise, and they're young attorneys, maybe even experienced attorneys, but people trying to learn a little bit more. One of the topics I wanted to talk about today is something that I experience a lot when I have clients who come in, and everyone associates personal injury with chiropractors, right? That just has seemed to be the, whether good or bad, reputation of it being an ambulance chaser, etc. But today's environment has changed, really, right? Where, I think right now, one of the most important aspects of personal injury, because of verbal threshold requirements, becomes your pain management doctor. Can you explain a little bit where pain management falls in the spectrum of treatment and what in the state of New Jersey people need to do and why they should entertain pain management in terms of the conservative care plan?
Yeah, absolutely. So as you mentioned, multiple specialties are involved in treatment of the patient with the pain after the injury. Chiropractors have a very good role and traditional role in providing treatment. Therapists, physical therapists also provide good treatments to patients. But for last, I would say 15 years, we evolved as a subspecialty that is really focused is on treatment of musculoskeletal disorders and neurological disorders. As a physician who went to medical school, we train on how to deal with trauma. Injury is a trauma. It's a part of that. A function of your body will become less because of a process of a mechanical injury or psychological injury. It's very essential a physician evaluate you truly after an injury and not only check your back and shoulders and knees and alignment, but also check if you have any traumatic brain injury, any psychological damage, any nerve damage. So aspect of the medicine is wide compared to just musculoskeletal in injuries, and a physician can provide that. And pain management on top of that has the tools to provide treatment further more than just a conservative treatments, like providing injections, minimal invasive procedures, but not surgeries, not necessarily surgeries. One other thing that's very important is that what the tools that the pain management physician has in order to diagnose you truly, and that diagnosis will help you with your legal case. You want to know what happened to your body, and you want to use it in medical terminology that also is a legal terminology, and that's what a physician comes in.
So, Doc, that's great. Let's unpack that and let's narrow it down a little bit, right? To sort of, again, where does pain management fall on New Jersey's conservative care treatment plan? Because in New Jersey, one person can't just jump around. You can't go from, you want to go directly to one doctor or another, right? If you want PIP to pay, you have to go through a certain process because you have to get approved, right, to be paid. And they're not going to approve something like an injection, which we'll explain what that is later, until they've seen that you've done enough conservative care to require you to get there. So where does pain management fall on the conservative care treatment? Can you explain to the people listening what is conservative care?
So the New Jersey follow a specific guidelines, the New Jersey Care Path guideline. In Care Path, we have a specific diagrammatic, step-by-step treatments in order to patient go from point A to point B and C and D until the patient either receive full spectrum of like surgery, or no, patient can get better with just conservative treatment because it has just muscle spasm. Is no jumping from point A to point C or D. You need to go back to back.
Except, of course, emergency situations.
Except emergency situation, which is a different life.
Horrible accident, you're in the hospital and they need to do surgery.
That's obvious, yeah. So if you have like loss of consciousness and you are don't want to wait for authorization to provide your CT scan, MRI, or essential surgery.
Yeah. So you were saying,
but this is elective. You're talking about elective courses.
So where does pain management fall? Is it after chiro, after PT? How long of chiropractic care or personal PT care do you need?
The way I think that's supposed to happen is that the physician needs to see you first. The reason is this. With all the knowledge that a chiropractor has, but they don't have a knowledge of medical conditions with a patient. For example, it's a patient coming with high blood pressure that has an accident and now has symptoms of musculoskeletal, have a back pain and knee pain, but also has high blood pressure, also have migraine, also have medical conditions, also is a children who is a complete different story. A physician, as a first step, just the evaluation, at least evaluate it and say, check everything, check the neurological system, check the musculoskeletal system, check the bones, check the psychological aspect of the injury, and document it, and guide you like a quarterback in a football, yes? You have a quarterback that has ability to pass the ball to different people in different direction based on this strategy.
That's such a great analogy.
That's exactly a physician can do. And pain management physician has this ability to become a quarterback of your care in relationship with your attorneys. This will help you to first get sooner better, get very, very good care of whatever injuries you have, and more importantly, physicians document truly. So if you have a good documentation of all your injuries in beginning, when the end,
let's rewind for a second, right? Because I think you myth busted right there, yes. Which is great. I think we should really zoom in on that. This notion that everyone thinks that, and we talked about it when we did our intro, that you have the chiro, the traditional role is a chiro. You go to a chiropractor, they work you up and then move you to the next phase, is misguided, right? Because the evaluation you're talking about, while chiropractors do have specific training, they cannot diagnose things like traumatic brain injury, nerve damage, or otherwise. That has to be done by a medical doctor, right? MD or DO, which is the same thing, but a licensed physician. And if going to somebody like a pain management doctor, and correct me if I'm wrong, they will do all of that, and then you'll refer, or they may have their own. They go to a chiro or PT, which is physical therapy, and they get the treatment necessary there, but you can give them a full top head-to-toe evaluation because you're a licensed doctor.
Exactly. Point is that a physician is able to see you as a whole, not as a body part. And that's the difference.
Let's also, and love that, let's also talk about how, look, you have very conservative care. Some people just want to go physical therapy, a little bit chiro, they do some adjustments. Great, right? They don't want to put things into their body. They don't want to do injections, whatever it is. And we'll get into whether it really is an injection, a drug, or is it bad for your body. But then you have the final of the spectrum on your treatment plan is if you're just not getting better and that the conservative care is not working, the physical therapy is not working, the chiropractic treatment's not working, the pain management's not working, so the epidurals, so the trigger points. When none of that works, the last stage is surgery, which is invasive, and you A lot of people want to avoid that at all costs because now you're cutting into your body and it's a major operation, right? So I personally feel as though when a pain management doctor does the initial evaluation, they're right in the middle, which is where the person should be who's evaluating you. They're not at the end, which is the surgery, who, of course, every doctor is going to be responsible and diagnose only as appropriate, but there's always a little bit of a bias. They're surgeons, so they always see things through the eyes of a surgeon, which would be, towards surgery. And you have, whereas the physical therapist and the chiropractor, all about conservative care, right? Because they see it through the eyes of conservative care. That's how they're trained. Whereas pain management is right in the middle, where you're non-invasive, so you kind of have more of you're talking about a quarterback, you see the field a little bit better. The running back has his role, right? The linemen have their role, but the quarterback gets to sort of see the whole field, right? Would you think that that's a good interpretation of why it's important? Pain management
is an excellent interpretation. It's very good. I mean, I'm impressed with your. I'm gonna yell you. That's good. That's good. I mean, I think that you could have a good doctor too. That's true, because when a physician, a pain management physician, physiatrist, people who work in this area of musculoskeletal, they see you. They usually have also relationship and working buddies in the other spectrum too. They have a chiropractor they work with, the therapist that they work with. They also have a neurologist, a psychologist, psychiatrist, a neurosurgeon, an orthopedic surgeon who they work with.
Mm-hmm.
So sometimes, especially like in my practice, I have lots of these specialties under one roof. I can pick up the phone and say, hey, I see this. What do you think about this?
Yeah.
So this collaboration is very important. One other thing that is people are missing is this. Sometimes by the time a physician see you, some steps are not taken. I'll give you a very common example. So chiropractors and physical therapists, they work with the exercises, manipulation, adjustments. But usually they don't give patient medication.
Correct.
They cannot.
They can't prescribe.
It's part of care path guidelines that you need to give anti-inflammatory and spasm medication.
Correct.
In order to bring the inflammation in the body down, the injury down. If you don't see your physician, who's going to give you that? Then you miss that step. I have lots of patients that they come and I ask them, are you taking any medication? No, I'm taking as I need it. So that's not the way it's supposed to be. This is guided medical treatment that is very essential in early stages of treatment.
Okay, and that's a great point. Let's bring up another point that I find to be very interesting, and I want to know a little bit about from your position. Pain management. It's a broad term, right? A lot of people think, pain management means getting prescribed pills, right? That's, if I wasn't in this field, if someone told me to go to pain management, I'm thinking you're going to send me to a pill farm. They're going to write me a bunch of Oxycontin, so much of something I get addicted to. That's what I think about pain management. Is that pain management? And if it's not, at least when it comes to the spine and neck and back, what is pain management? What should people think when they think pain management?
Medicine become specialized, honestly, even yearly. Maybe 25 years ago, a pain management physician was a person who give narcotics, also...
Yeah, that was the word I was looking for.
Yes, narcotics. Give medication.
I don't even think I said...
Do the needle, injection, stuff like that.
But what's it today?
Today is completely different. We have pain medicine. We have interventional spine and pain management. We have even different specialties of medicine, like an emergency medicine doctor.
No, let's focus it down to when you hear pain management.
I want to say that because this guy's from different specialties, from psychiatry, from neurology, from EM. Pain management is a subspecialty. You need to come from another specialty to it.
So pain management can also include a psychological assistance because you have psychological.
Absolutely. The new approach of pain management fellowship programs now, before was just anesthesiologists and physical medicine rehabilitation. Now they take the students from specialties like emergency medicine, psychologists, neurologists, because they want to multidisciplinary action on this. They don't want to have just narrow their mind. You don't want to look through the keyhole. You want to have a wide window and see all the aspects of the pain management. So yes, 20 years ago was giving medication only, but now we have a wide variety from biomechanical evaluation all the way to minimal invasive endoscopic spine surgeries that the pain management service can provide you. And that's really a huge arsenal in your disposal in order to do this best service for the patient.
So, Dr. Dorri, let's talk about another category, right? Which is effectively who can choose you. Everyone should be entitled to choose their own doctor, but that's not always the case. So for a lot of you new attorneys out there, or just getting into personal injury, and you realize that there's occasions where workman's compensation and personal injury cross paths, right? Can you explain to, and even patients, that if they get hurt, they're hurt on the job, they fall, they're driving, where in that pyramid can they choose to come to you at NASPE, or they have to go through, do the insurance companies get to decide where somebody treats?
In the state of New Jersey, in matter of motor vehicle accidents, you can choose any physician you want to go. There's no direct care from adjuster that you have.
Mm-hmm.
In work compensation, that injury happened in the state of New Jersey, not in New York, the insurance has ability to direct your care, and your doctor, they can direct you to a specific doctor. You can choose to have a second opinion from another doctor, again, from within that network.
Understood.
But in matter of a slip and fall, like injuries as a result of a fall, again, you can choose your own doctor on the guidance of your insurance, or you outside your insurance. Doesn't matter.
So general rule of thumb, if you're in a car accident, you can choose your own doctor. If you're in a slip and fall, you can choose your own doctor. If you are in a work accident, you can't choose your own doctor. As a general rule, you have to go through your workman's compensation claim, and they will refer you to a doctor.
True. One exception in motor vehicle accident that happened during the work. For example, you are a truck driver and you are working at that time.
An employee,
you get an employee. You're working, you're delivering, and you get into the accident. That consider a work compensation. That would not consider as an accident.
Correct.
But if you, for example, just truck driver, you finish, you sign off, and now you're using your truck to go to your home, and you get to the accident, this is an accident. So you can see any doctor you want to.
Understood. Let's talk about another category that I personally, as an attorney, I think people miss so much, is when they get into the accident and they think they're fine because at that moment they don't have pain, right? And I think so many people don't realize that pain is an instant, especially when it relates to your spine. So from a medical position, can you explain to the people listening and watching what I mean when I say, just because you're not hurting in that moment doesn't mean that you have not suffered an injury to your neck or back?
Very, very good point. I mean, that's a very common that patients, your clients, my patients, get to the accident and they said, I didn't have pain for a week, and all of a sudden my pain started and it's getting worse, doc. I mean, now after 3 weeks, 4 weeks, I have worse pain that I had with the time of accident. It's very simple explanation from it. The fact is this: your body first go to the step of protecting you during the accident. Most common injuries that happen in motor vehicle accident is something named whiplash injury. We get to that later. But whiplash injury, your body right away put all your muscles to a spasm and doesn't let you to move. It's kind of like a brace your body in a shield. So it doesn't hurt you anymore. This may not cause you any pain, but the chemicals that build up in your body, it will irritate your nerves, create inflammation. Inflammation can take weeks to build up. And when inflammation build up, create another chemicals that your nerve endings just start to filling, these chemicals, and then all of a sudden you have pain. But our body is not a tool. It's a complex combination of multiple structures that they are living together. And if one go down, the rest of the body try to protect it, but in some point say, what's going on is an alarm going off. And that pain is your alarm. Pain is not source of your misery. It's an injury that happened to your body, and pain is your alarm. Lots of people shut down this alarm fast. Yes, they take medications. They do lots of stuff to shut it down. That's wrong. Lots of emergency rooms, when you go there, right away they give you a pain shot, a narcotic, even like Dilaudid or something to your body. That's wrong, because actually you're shutting the alarm down without knowing what's going on.
It's like your building's on fire. You turn off the alarm, but you don't look to see where the fire is.
Exactly.
So it's accurate to say then that really people who just in that moment, they should still get checked out, even though if they don't feel pain, because it could just be their body overcompensating. And when that adrenaline and everything else wears off, and the chemical reactions that were there to protect kind of wear down, then they're going to begin feeling the pain. Then the pain's going to begin setting, and it was a result of the injury that happened a week ago.
Look, this is very common that people come to me and say, it was a fender bender. It was not bad. My car is not damaged too much. Why I'm so much pain? Doesn't matter. Your car is, I would say, 2 tons of metal that hitting each other. If you calculate the energy that is coming to your body and jolting you, you will know that this amount of energy is huge. Your body cannot handle it. The fact that you don't have pain now doesn't mean that you're not going to have pain in the future. And the sooner you know, is better. And how do you know that nothing serious happened? In my career, I have multiple cases. The patient bleeding brain did not go to the emergency room right away. It was a little hit to the wheel as the accident happened. Yes, the airbag deployed, but that doesn't mean that you're not going to have a trauma to your brain.
Yeah.
So fender bender, small accidents are not maybe life-threatening, but they can damage you. They can injure you, and you need to get checked out.
So great you say that, because I can't tell you how many cases I have where the insurance company goes, there's little to no damage. And, by way of background, I was an engineer before I was a lawyer, and I'm sitting here talking to an adjuster, which I'm sure they're all very highly educated, but I don't think any of them have science majors that I'm aware of. And I'm like, I tell them, I was like, well, what's the equation for force? Right?
Exactly.
What do you mean?
Half an MD2.
I'm like, you're looking at a picture and you're trying to talk to me about the transfer of energy, right? That's like looking at an apple and tell me how good a peach tastes. They're not new with each other. So yes, of course, if there's a lot of damage, well, it's more visually evident that there was a substantial transfer of energy because it caused the cars to get damaged more. But when I'm talking to these adjusters, and I get technical because they annoy me, I'm like, are you comparing the flesh and spine of a body to the tensile strength of plastic or metal that's in a bumper? How you can, if the bumper doesn't bend, that meant my spine doesn't bend? Because my spine's a lot softer than a steel bumper. It's idiotic.
Such an interesting conversation is this. And I think that we need to put it at another time and talk about it. Our evolution did not design for driving.
But we cater to old people. And I'll talk about evolution. I was dropped on this earth. Was this Stokes' star? No, I'm kidding. But yeah, so our evolution was not designed.
It's not designed for driving. So what an injury that is a 2-ton car, a Hyundai Odyssey that hit you from behind, and you just break your bumper, but it can damage the disc in your...
This is how you know he's a father of multiple kids. That's not me, man. He's not an example.
Yeah. So it can damage your cervical spine disc. It can inflame your nerves. You don't even realize it until 2-3 weeks later.
That should bring us to another point. And this point is permanent injury. Doc, why in my profession, right, if you don't have something called verbal threshold, which is you have to pay more for insurance, because back in the day, the insurance lobby money was strong in Jersey. It still is, but, we also now have a lot of lobbyists fighting for people's rights, as opposed to insurance companies seeking their profits. And we have to demonstrate in most cases that there's a permanent injury. That means that no matter what, you're not going to go back. So soft tissue damage, things like that don't apply. And one of the main factors of a permanent injury, at least as we see it in our profession, is what we call a herniation, because herniations never get undone. And herniations are caused, and I'll let you explain by what. Can you explain to me and everybody else how you identify permanency or permanent injury? And actually, if you don't mind, we have a model here. Maybe you can show people what is a herniation and why once you have it, it's permanent.
We don't have a body shop for our body. When you get to the accident, you go to body shop and change the bumper of your car, change the front seat, change the wheel, whatever is damaged, change it. But we cannot, when it's something damaging your body, it does not have any replacement shop for it. Then you go and order a disc. This is a spine. So why we are talking a spine more than anything else is that because of that whiplash injury I talk about, most of us, we have whiplash, usually seatbelt.
I don't mean to interrupt you, but I'm just gonna say a point here that I think is very relevant. How important spine and neck injuries are. As I'm sitting here, because you treat me, I have 5 herniations in my neck. Like right now, I have discomfort in my top shoulder blade, all through my neck. So when now you start explaining it, I want everyone to really think about the fact that even me sitting here, I'm sitting here in pain because my body looks fine. I look like I'm very physically fit, but what's happening on the inside, you can't see.
Is a subjective understanding of your pain, and nobody can see it. Nobody can say, "Oh, your pain. Oh, that's my pain." Cannot see it. So a spine is bones, and between bones we have this disc. We have multiple of them. Top to bottom. We have these bones that are very interesting structure. It will protect the nerves that are supposed to control your hands and your legs. And
so the nerves are just, we could do it on video. Yeah, this is going to be the nerves, right?
It's a little exact. This is a model. So the nerves are more look like a horsetail in the back. In the neck is a spinal cord. And each nerve is given a branch to the side. So each one, so imagine this is like this. The nerve come out from each side.
Like a tree root.
Yes. And each muscles of us and sensation in your body coming from different nerve roots that all of them connect to a spinal cord. A spinal cord go to brain, and brain understand the life around you. Yes, understand how you walk, where you're going, what direction, where is your body part sitting, what sensation. This is hot, this is cold, different things coming through the nerves.
Yeah.
So this is structured design. In the same time, also, our main thing that we do compared to other animals is that we are walking upright. This is designed for walking upright. And if this get damaged, the nerves get damaged, the structures in this cushion named disc get damaged, then you have problem. You're going to have biomechanical problems like not ability to walk right. You can do the, limping. You need to use assistive device, or also you can have pain that you cannot even do your daily activity. You cannot bend forward, backward. You cannot exercise. You cannot go to gym. You cannot sit to work because this become a painful.
Well, you can, but with pain, unless it's that bad where you're paralyzed.
Okay, so in one of the things that we always document is the daily activity function level. We assess that. We ask you, can you go to take your shower like usually you do before? Can you play the golf as you usually before?
No, I can't.
Can you go to gym? Can you drive like you've been driving before? Can you turn your neck and do the driving right way? We are documenting this. This is a function. It's not just about pay. Another thing that physician can do is that assess the function. Now, this is the structure. This is a little exaggeration of the size and so, but we're going to use it. Herniation that we talk about, and you mentioned it, is very always give this example. Imagine a donut jelly. That's the disc.
Well, so look at this.
I will show you on this too. So you can see that. So if you pressurize the disc too much, because it's damaged and little cracks that happen, the jelly from inside push outside. This is something like this. So you can see a little push out. I will do this again and again so you can see what happened in herniation. So this herniation can happen in front, in the back, on the side. Depends on where it's at. It can have a nerve damage. So you see this nerve now supposed to come through this hole. The nerve is squeezed by this herniation. So this is what you have. The nerve doesn't like that. It becomes inflamed. The disc itself, this moves. It will move side to side, bend forward, backward. If the disc is painful, then you're going to have pain. You have a discogenic pain. This structure in the back, its name is facet joint or zygophysial joint. This injured in the accidents a lot. That can also cause pain. So the between here is a ligament, named interspinous ligament. That can get damaged. On top of that is all muscles. The muscles can get damaged. But permanent injury is not happening to muscle. It usually happen to a structure that cannot repair itself, which is disc. The structures that cannot repair is this and the capsule around the structure of the nerve. If it get damaged too much, then it cannot repair itself. But it's just inflammation. That's where the pain management come through. We provide the treatments and we can reverse some of the injuries to the nerve, but not all of it. And disc, when it's damaged, is damaged forever.
So, Doc, when someone comes to you, we just talked about what is a permanent injury, and you just explained multiple things. You talked about, well, first you have the muscle, then you have the capsules, and you kind of went through the physiology of the body, right, as it relates to the spine.
Yeah.
But someone walks in, you can't see that, right? When we just talked about how I may look okay, but I'm sitting here in pain because of my herniations in my neck, right? So in your context, how do you, as a doctor, catch it? How do you diagnose it? So you know that people have it, and how do you know that it happened from a specific incident?
The first line for diagnosis is to examine the patient. After you're listening to history of the patient, we examine the patient. Examination, believe me, lots of people put it down on examination, but if you do the examination right, you're going to get a list of possible diagnoses in your mind.
Physical exam. They come in, you see them.
You examine different methods, did some maneuvers. That's actually lacking in lots of, because they don't spend time.
Yeah.
We spend lots of time. My first initial visit, it takes 1 hour for patient to go through everything in the examination.
Well, that's 55 minutes of filling out your forms, right?
No, that's not doing that. So the first office visit actually is a long office.
Yeah, I remember.
And another thing is that always I tell that when the examination create a list for you, then you need to go after, now get the objective findings. When I say I have pain, this is a subjective matter. I cannot prove it to you. I cannot say, hey, this is pain. This is my pain. Look at my pain.
And everyone has a different threshold for pain.
Yes.
Pain means different things to different people.
For purpose of me going to the next level, I need to have objective matters. We have two major objective examinations. One is anatomical objective studies like X-rays, MRI, CT scan, all this kind of pictures from inside the body with different technologies that can you give more data about what's happening inside of you. This is very important to how to get it done. In New Jersey, is a specific rules when you can get an emergency MRI or CT scan when you need to wait after the conservative treatment, you get an MRI. So if the physician knows that, it will save lots of headaches because you're not going to get denied. You're not going to go to appeal the process. If you know this is a process, they will approve it for you. So
let's go back to your diagnosis. So we talked about subjective, which is I feel, or things that are just in someone's individual opinion. Objective, you have diagnostic testing. So you talked about x-rays, which is not muscular, it's bone.
It's bone.
It's all.
Bone, soft tissue, alignment, how the bones looks like, if there's any spasm you can see. And sometimes it's an injury, it's a trauma. Sometimes you can see foreign body inside the body. A small fractures, a small dislocations, you can see that.
Okay. Then the next, I believe you mentioned, was MRIs.
MRI.
Which is, magnetic rays going through you, which basically will show things like a herniation or otherwise, because as it bounces back and creates an image, you see the lines and you see the deviation. So you see the actual bulges where a radiologist sees it.
MRI is revolutionary in our work. Actually, MRI is one of the things that, since we have the MRI, back in the time, we had very difficult time. You need to inject the contrast, you need to see with the CT scan, the difference between them. You don't even see the soft tissue good, the disc good. Usually CT scan is another type of X-ray, but high definition X-ray. Yeah. So MRI really changed everything. Now we can, with the strong MRIs, like the 3 Tesla MRIs, we can see the tiniest the changes and even damages that happen now compared to before. Not every bulletin.
Not yet. That's why. I'm going to get to that, right? So MRIs, what other objective testings do you have to determine there's an injury?
This is all pictures, yes. I always give the example of this, that if you leave your kid in home and you forgot to, turn your stove, you're going to tell your kid.
Then you call me because you're going to need a lawyer.
Yes. Well, you tell your kid that, okay, can you tell me that if the stove is on or off, and take a picture of it and send it to you? Do you know it's hot? Do you know it's not hot?
No.
You don't know.
No.
It's because what it needs to do is that they put the thermometer and say, oh, is this hot? I feel it, yes?
Yeah.
So we have a second type of objective studies, named nerve conduction study, or EMG, as well as EMG. This will physiologically tell you if the nerve is damaged.
Mm-hmm.
This very depends on who is doing it. It needs to have a specialized person, like I'm board certified to do this. So it needs to, a board certified person to do it is very based on technical, and that gives you more data regarding nerve damage or not.
Well, I remember when I came to see you and I was telling you I was in pain, I could tell you're like, all right, everybody says that. But, and while I know you appreciated what I was feeling, I remember you doing that test on me. Yeah, I actually remember your face when you were doing it. And I think at that moment I realized the reason you're making that face is because you're looking at, to your point, objective results. Like you were looking at the chart and you were seeing the numbers coming back. And at that point, I could see the concern on your face. Like, okay, well, there's damage here, right? So these objective findings are very different from someone just telling you something. You're seeing real-time data scientifically that supports an injury.
Real-time data is very important. This is very important. Like, other tool we have is ultrasound. It gives you real-time data.
Yeah, real-time that I mean.
Is right away you see what's going on. You can use it right away, right there under your guys. It's amazing how ultrasound changed. When I finished my medical school, ultrasound machine was the size of this room.
Yeah.
Now is the size of a laptop. Even some ultrasound machines are size of your phone.
So guys, that's how old Dr. Dorri is?
I'm very old. So the fact is this. You use all these diagnostic tools to prove your initial diagnostic list. A physician needs to make that list first.
So chiropractor, physical therapist, they can't do that.
Some of the experienced one by their experience they know, but it's really a systematic way a physician needs to do it.
Can a chiropractor do a nerve test?
No.
You have to be a licensed.
You need to be, if you really want to know, and lots of people are doing it now, unfortunately, but 2 specialists are able to do the nerve test. A physical medicine rehabilitation or physiatrist, as a part of the residency, they do it. At a neurologist, they need to go to a fellowship and get trained on nerve test and EMG. Nerve test and EMG is very, very complicated knowledge. if you go and see the books of it, is bigger than books of orthopedics.
Yeah.
It's so complicated. The point is this, that all of this data come to an algorithm in your brain and say, okay, now which one is my number one? Which one is number two? Which one is number three? The number one for legal purpose is different from medical purpose. Let me give you an example. The nerve injury for me is number one of top of everything. I go after nerve injury always and treat that first. Even though the patient has a disc herniation.
Because that's immediate pain. When your nerve, like you burn your hand, you're feeling that pain instantly.
And the nerve injury is irreversible. I need to treat it fast. I don't have that much time. I have patients, some of clients that we send in lawyers, that they waited 6 months, 1 year to get treated by pain management. They've been in the therapy for 1 year. By the time they come to me, this nerve injury is chronic, it's done. You cannot do anything about it. It's kind of become a permanent injury.
But if they came to you earlier and you diagnosed it earlier, it's like the fire. There's still a fire, but you could have put it out before it burned everything down.
Before scarring everything down.
Correct.
So this is very important. So this is a diagnostic part.
So it circles back to why it's important to have a physician look at you before the traditional role of a chiro or otherwise.
I want to expand that a little bit further and say a physician, not an extender to the physician. Lots of practices, unfortunately, because of financial issues that now we're facing in medical work, using a physician assistant,
PA,
or nurse practitioner to see you. With all due respect to their knowledge, I went at 19 years to medical school and different specialties. The PA go 4 years to a school and then wants to diagnose and even perform some procedures. This is a dangerous part, because if this practice, you don't see the physician unless you see the physician in the operation room, is a problem with that practice. In our practice in North American Spine and Pain, my neurosurgeons see the patient himself. Even though if we may use a PA as an assistant, but the physician is assisting it. The orthopedic surgeon same, the pain management same, the foot and ankle surgeon same. This is something that really differ a practice from practice, and is very hard to find now. It's very difficult to find a practice that not using extenders all time. It's okay to use an extender for a follow-up, but not all time you see just it.
So that's great. That's a great point. So for even lawyers who may refer their clients to doctors because they think they're good doctors, they should be wary of, and again, look, as an attorney, of course, building a case is important. It'd be silly to say it's not, right? But it's also respecting the doctor to do the diagnosing and to do his job, and having trust in the doctor. I think some lawyers sometimes forget their position. And when we do refer, and when we refer to doctors, at least for me, it's always because I think that I'm doing my client a service by sending him to a good doctor, whether it's a chiro or a physician, that's going to make them feel better, right? Because there's no money in the world that can replace an injury or can compensate you for pain. So from that standpoint, you're saying that lawyers should watch out, and so should people who are just injured, who don't have attorneys or are just treating on their own, to make sure they're actually, if they're paying for it, they're seeing the doctor, not a physician's assistant or nurse practitioner. And again, no disrespect to either of them, but the reality is one has almost 20 years worth of training before they get to do what they're doing. The other's 4+.
And on the law, this is on the legal aspect of it, the physician assistant cannot testify with you. So whatever findings they have, whatever notes they have, is not legally, you cannot use it. It's not board certified. You cannot put that person on the stand.
Yeah, no, listen, as a lawyer, there's so many times where insurance companies and the defense, they are not looking to pay what cases are worth. And if they can find any reason, they do it. I haven't yet experienced that issue because I've been fortunate enough to have doctors like you in my referral base where, I know that they're being treated, but I can very much see an insurance company being like, well, that's not acceptable. And that brings us back to now, if you're an attorney listening to this in New Jersey, you need to file a certification of permanency. And there's case law on it where back in the day, people used to use chiropractors. And they say, no, you have to use a person who specializes in the injury area. So if it's a spine injury, something like a herniation, you need to have someone who is certified, board certified, trained. Doesn't have to be board certified, but should be, trained. I haven't had the issue yet because I have, doctors like yourself in my referral base, but I can very much see an insurance company who they're trying their best not to pay to ask me a question like that. Because, like I said, we need to file what's called a certificate of permanency. And the law, people used to use chiropractors, but the law now is that that person has to be knowledgeable, a specialist in that area of the permanent injury. So if it's spine, it has to be someone who is a specialist in spine. And they don't consider a chiropractor to be someone who could read MRIs or be diagnostic in a spine injury beyond what's in the scope of a chiropractor's ability to diagnose spine injuries. So, PAs can't do it either. You do need to make sure that if you're referring as an attorney and you want to work your case up, it is to someone who is board certified. That's just an additional qualification. Listen, Doc, have you do a lot of PIF, which means that you're subject to these depositions by these insurance defense companies. They come at you, right? In that capacity, have you ever experienced a scenario where it mattered?
I'm sure that you have this. No, you, not me. No, that's what I'm saying. I'm sure as your lawyer, the first question you ask from the other side doctor, if they have a expert on the witness, you said, what is your qualification?
No, I ask how much money they get paid by insurance every year.
But so the qualification of the physician is the first question they ask you.
Tell us about your personal experience.
Last week, I had 4 depositions for New York Insurance Fund, which is like a work compensation board for injuries in New York. I'm board certified in Work Compensation Board of New York as well. So the first thing that the guys asked after my qualification said that, is that your patient seen by you or by your physician assistant?
Interesting.
First thing that asked.
Right out the gate.
Right out of the gate. Say that, I see that you also have, because he went on our website and see, we used to have physician assistant. We not use them anymore. But he said that, you have a physician assistant in your practice. Is this patient seen by you or by your physician assistant?
Mm-hmm.
So he was definitely after saying that, are you the person who are actually seeing patient and treating patient, or your extender see and you sign for them? It's very important. In my opinion, I'm coming from very traditional medical education. In my opinion, assistant is an assistant. It's not supposed to be main person. It's supposed to help you with the process, not supposed to replace you because it's cheaper to hire them.
Understood. That's a great answer. Let's talk about another topic. Let's talk about the medical implications of motor vehicle accidents. What is the most common type of injury you see in your realm of medicine, which is pain management, that results from auto accidents?
Spine injuries. By far, spine injuries are the most common cause of injuries that after accident happens. Definitely, the spine injuries are part of the problems that unfortunately is so hidden parts to it that it's kind of like a journey. Some of my patients come in and say, you didn't tell us in the beginning that you may have like a mid-back pain or thoracic pain. You didn't tell us that my pain can go from a spine. The pain that I feel in the elbow is not from my elbow. It's actually coming from my neck. So the spine injuries are the main source of the injuries. Sometimes they're mimicking and referring the pain to other body parts, and you think you have a knee pain, but actually it's not knee pain. It's coming from back. And the reason is that the structure that our cars are. We're sitting, we have a seat belt on that protect us from hitting our head anywhere most of the time, or fully, if it's not a bad accident. And a spine is the moving part in that aspect. The knees are in a good position, it's bended. The elbows are bended or on a wheel. So most of the time, I would say the spine injuries by far is the most common injuries that we have after accidents.
So Doc, we have we have a lot more to go over. But let's wrap today up with the actual procedures. So I'm going to talk about epidurals because I've experienced them. I've had 3 or 4 with you, and I know it's horrifying for my clients. They think they're having surgery, right? And yes, it is invasive, and well, I chose one time not to go under anesthesia, and I very much regret that. But you go under anesthesia. But is it as bad as people think in terms of what you're putting into your body, or is it something that just gets absorbed and is, I don't want to say it's natural, but it's something that doesn't have side effects? Because I'm sure everyone is wondering, well, I don't want to deal with the side effects of that procedure.
Epidurals are being done for last, I can say, about 80, 90 years.
They were doing this 90 years ago?
Yes.
With what?
With no X-ray.
How'd they even hit the...
Because the beginning... Okay, let's talk about what is epidural. What is epidural? Epidural is not type of injection. Epidural is a part of your body inside your spine. It's a space. Imagine this room is your spine. The epidural is a part of this wall. This is a dura. Dura is a little tent around your spinal cord. Name is dura. It's full of fluid. Fluid is around your brain and around the spinal cord. Believe me or not, the spinal cord and brain are actually floating in the water. That's how it works. And dura is very thin. It's between dura and the rest of the spine is a space named epidural, means around the dura. This is space.
I thought epidural would be an injection.
No, epidural is a space. Now, 80 years ago, they used it for different purposes. Any person who went through the delivery after pregnancy for a new baby experienced that they offered them an epidural for not feeling the pain during the delivery.
Yeah.
And that's the first thing actually started the pain management. It's not used you don't need to use any X-ray. You just by feeling, you find this little space here and they put the needle through it and they put some numbing medication with some other medications that you basically don't feel the pain. That's how they find out that they can put medication in that space and you don't feel the pain.
Oh,
that's how epidural.
That's very interesting. So it's not per se like an injection into your spinal cord. It is taking a numbing cream, so to say, a numbing concoction. You apply it to the area, and that's why it doesn't cure or fix your herniation. All it does is relieve your pain because it's like getting an injection somewhere, or when you spray your hand with that freezing thing, so makes it numb.
Correct. In the beginning was like that. It was just numbing medication. Then with development of the steroids, cortisone we name it, they created a specific cortisones that have no preservative in it. So you're able to inject them to a spine. Why is it important to use a specific cortisone is that because let me tell you why we're doing the epidural in the beginning. Yeah. Why you don't give the medication by mouth. Yeah, it's like you do for blood pressure.
Yeah.
Problem is that epidural space, because it's so mobile and it's so fragile, doesn't have very good blood supply. The disc doesn't have very good blood supply. So they figure out if they give medication by mouth, sometimes you give medication, but sometimes you give cortisone in period of like 6 days to patients in hope that they get better. But the problem is that the medication doesn't reach. The medication you take by mouth is go to your shoulder, to your elbow, to your blood flow, everywhere, yes? So you want to specifically use a small dose of medication and deliver it right to the area that is painful and cause the inflammation.
So it's targeted. It is a targeted
drug delivery.
Okay.
So this when medication is delivered, that's the process is epidural steroid injection. That's the complete name. Everybody say epidural, but is a name to it. Epidural steroid injection.
It's an injection of a steroid to your epidural.
Yeah, exactly.
Understood.
So this
is it something that if someone does that, are they good? Is that forever?
Difficult questions to answer. Depends on what. That's always the patients say, "Oh, my grandma did it and did not work for my grandma, or my cousin did it and did not work. Really, this structure are so complicated that everybody situation, like your legal cases, yes, somebody cannot tell you, oh, did you win this case? Can you win my case?
I'll speak from my own experience.
Yeah.
And I've done it multiple times with you. I feel some relief for maybe 2 to 3 weeks and it comes back.
Yeah.
It's not permanent.
Yeah.
Body just says, okay.
So, but that's, remember I talk about care path guidelines?
Yeah.
As per care path guidelines, which is a scientific research, it's not just some people sit around and create these guidelines. They sit, they review all the articles, evidence-based. That's how we do in medicine. We are talking about science. We don't just decide to do some procedure because we want to do that procedure. This procedure developed, went to the research. The research showed the evidence that this procedure works or not working, or this amount of time working, or avoiding surgeries or not avoiding surgeries. And then they put it in care path guidelines. So in order to, if you have a specific diagnosis of lumbar radiculopathy, which means that your nerve inflammation caused the pain to refer to your body parts, like your hands, or in case of the neck, or go down to the arms in case of the upper part or lower part of the neck, or it going down to your leg in case of your lumbar spine. That means that your nerve is inflamed. When you do the epidural injection, if your inflammation is not too much, your pain gets better. I give you exact number. For example, if I say I do 1,000 injections a year, I need to send 40 to 50 patients to surgeon. So
40 to 50%.
40 to 50 patient, not 40 to 50%. So that 1,000 injection done, for example, for 150 patient, I need to send 1/3 of them surgeon, 2/3 they get better with epidural injection. They don't need to do anything else. Is that in future they need again treatments like 2 years later, 3 years later? I don't know, but not everybody is a surgical candidate. We want to talk about that too. So we want
and we'll get to that. I think the notion of an epidural, is it a temporary relief or is it a permanent relief? Because you're never fixing your disc.
Depends on your injury.
Okay.
It depends on extent of your injury and severity of your injury.
Let's talk about a herniation.
Even on herniation, depends on how big is your herniation we have. Let me show you. I mean, this is just for showing. It's not really this. So this is a herniation. This is This is a herniation too. So difference between this and this is a size.
Yeah.
Size of herniation, amount of damage, how many levels are damaged. Is that the crack in it, we name annual tear or not? Is that high intensity zone or not? Is that the disc is inflamed or not? Is really changed with multiple factors. So yes, if the disc is huge, you have significant issues, you may not, it's possible we don't even go through the epidurals. We send you right away to surgeon, say this is a situation can get really bad. We send the surgeon say, listen, look at the size of the disc herniation, you need to do the surgery now.
Okay. Understood. Doc, thank you so much for coming today. I look forward to talking to you more and, growing on this area of law and medicine as it relates to personal injury and workman's compensation.
Thank you for having me today.
Absolutely.
And it is always a pleasure to work along with attorneys who are very knowledgeable even in medical field, and they understand the medical field so good that they can guide their clients in the best way. This is the best type of attorney I usually work with, that they know the medical field as well as the legal part. We don't know that much about the legal aspect of it, but we really appreciate that you are interested in this, and we hope that we can work together.
So listen, everyone watching, thank you. Obviously, we have shorter reels on our other social media platforms, but for those of you who are listening to this or watch the entire video, listen, feel free to comment. If there's something we said that you want to know more about or you have questions, I know Dr. Dorri will monitor the comments on it, so will I, so we can expand a little bit on those areas and those topics. This was kind of a general overview of certain things, but we will get into more details about them later and break it down further.